Dr. Maryam will talk to us about barium enema, the procedure and the radiologic pattern, which is, I think, is an interesting topic.
Barium enema is a radiological procedure that leads to imaging of the colon and the rectum, and it's very sensitive for mucosal patterns and also for the colon configuration. However, it's now superseded by CT colonoscopy and colonography, and it's, as I said, reasonably accurate, minimal invasive, and no sedation required on routine basis. Usually, we will use X-ray and the fluoroscopy in this in the imaging procedures. That's it. Indications used for those patients having symptoms of, for example, anemia, or having melena, having any abdominal pain, signs of obstruction, and also it's used for inflammatory bowel diseases, Crohn's, ulcerative colitis, ischemic colitis, and it's used in as a screening for CA colon, in inconclusive colonoscopy sometimes. And for, as I said, for the patency, for the caliber of the colon, it's also used. In the contraindications, it's contraindicated in patients for whether having rigid biopsy, those having pseudomembranous colitis.
Having what?
Whether the patient used have prepared and did recent rigid biopsy and also rigid sigmoidoscopy. That's it's an absolute contraindication. However, in the flexible,
why it's an absolute contraindication?
For the rigid biopsy, usually it's should yes, it's of course of risk of perforation, and also it should be
which causes the risk of perforation?
Because it's a rigid biopsy, rigid for the forceps used. So
there is a risk of barium leak. Yes. Due to perforation caused by the biopsy. If the biopsy caused any perforation, the barium will leak to the peritoneal cavity, will cause a big problem. Okay.
And also in patients with toxic megacolon, those with pseudomembranous colitis, in the flexible sigmoidoscopy, it can be used after 24 hours. The barium examinations can be used can be done after 24 hours. And also the relative contraindications in those patients that have incomplete bowel preparations, the scout film should be done at first, and also to see whether any residual stool have presented in the X-ray, in order to see it in the X-ray and revisualize the patient. And after that, in the recent barium meal should be done after 5 to 7 days. In an old bedridden patients, usually it's a relative contraindication that needs more maneuvers in order to do the barium enema. That's it. The methods, we have double contrast, barium enema, and also single contrast. Usually double contrast, it's as I said, it's used as a method of choice for mucosal patterns. And the single ones in children, those patients that for the localization of an obstruction, that after that you should do the barium enema used, and after that the immediate surgery should be done. And the reduction of interstitial, usually now it's not done by barium enema. That's it.
How is done?
Now, I think by air.
By pneumatic reduction.
The contrast media, the double contrast and the single contrast. The double contrast on high density, the polybar, magnesium sulfate barium barium used, and also we will add air also in a concentration of 60 to 120% weight per volume used, and in the single contrast barium enema, usually low density barium used 12 to 25 weight per volume. The patient preparation, we have many regions for patient preparation. One of them, you can use a low residual diet, low fiber diet, in order to have lower stool and fewer stools, fewer lower frequency stools. And also on the day prior to examination, you can use a plenty amount of water in order to prevent rehydration, and also using sodium picolax magnesium citrate and sodium picosol or bisacodyl used for 2 times at the day prior of examination and the day of examination, and also the only fluids should be taken. And the day of examination, only, as I said, bisacodyl used. And after that, you should stop in order to have a colon, a clean and dry colon, in order to have a good mucosal pattern. And also on the day of examination, those patients that are having diabetes mellitus and also those with heart disease should be prepared. Should be admitted in the hospital 24 hours at least in the ward in order to have those with diabetes for sugar, random blood sugar control, also for the in order to have bowel preparation, better bowel preparation, and for those with heart diseases, they should take antibiotics. They should take antibiotics in order to prevent any causes of infective endocarditis. That's it.
Okay.
The procedure in the double contrast barium enema, we should, in order to focus on the quality of the image, we should have a good mucosal pattern. Depends on the mucosal, it depends on the barium concentration and suspension, and also you should have a good colon distension, and also the image should be in projection and in profile. And a scout film, that's an AP abdominal film, of which the central ray should be directed at the level of L4, should be used in order to see any residual stools are found in the bowel or not. And the patient should be lie in a lateral position, whether left or right. And the next one, the lower leg should be slightly flexed and the upper leg should be fully flexed, as in this position. And after that, the catheter tip should be lubricated and then inserted into the rectum gently, and not exceed 3 to 4 centimeters, and taped firmly in position for prevent slippage. And inflate the rectal. Usually, the inflation of the rectal balloon is used only in those patients that have rectal incontinence. But before this, you should do additional rectal examination to see any masses, any lesions in the rectum. And the rectal balloon, as I said, it's not used in every patient, cause risk of perforation. After that, the connection should be made with the reservoir and the hand pump for injecting the air. As I said, after inserting the tube, you should add for relaxation of the muscles, like rectal muscle, you should add either Buscopan or glucagon. Buscopan is contraindicated in heart disease, cause risk of tachycardia, and those patients with having glaucoma, because its cholinergic effect lead to more increasing in intraocular pressure. And also the infusion after that infusion of the barium is commenced. Intermittent screening is done by whether X-ray or fluoroscopy, and after the barium is terminated, the insertion of the barium terminated at the level of hepatic flagell, tilting the patient 10 degrees. After that, inserting the air gently into the pump, into the bowel, forcing the column of the barium toward the cecum and producing double contrast. Whether air or CO2 is used, air leads to post-barium examination abdominal pain. So sometimes, many times CO2 is used for better post examination, having less abdominal pain, or better absorption. After that, the exposures, we have many exposures. One of them, the lateral position, in order to view the rectosigmoid area, and the central ray in that region should be directed at the level of 5 to 7 centimeters of symphysis pubis, in order to see the rectosigmoid area. After that, the apirectosigmoid area, and this another Yes, another projection of the at the level of the 5 to 7 cm above the symphysis pubis also, but directly. And the AP abdomen after that single and double contrast barium enema is used in order to see in order for demonstration of the spleen and also the rectum. This is the double and single contrast barium enema. But the central ray should be at the level of L4. And the right posterior oblique usually they are optional. And in this image, the patient should be tilted to the right, 35 to 45 degree, with central ray at the level of the L4 again, and the splenic flexion and the ascending colon is seen. And in this left anterior oblique, usually it's again optional. Then turning to the left, and again 30 to 45 degree, seeing in order to view the hepatic flexure and also the descending colon. The right lateral decubitus position, you see the medial part of the ascending colon and the lateral part of descending colon. The central ray, as I said, in the level of the L4, and the left lateral decubitus. In this, see the lateral part of ascending colon and the medial part of descending colon. The prone decubitus position. This as a cross-table view for seeing the again rectosigmoid area. That's it. The AP angle prone, it's angled caudally at the angle of 40 degree in order to see the air fluid level, rectosigmoid. And after that, the supine position is used in order to see whether any residual barium.
Post-evacuation.
Yes, post-evacuation, in order to see any residual volume, and also encouraging the patient for drinking more water, and also eating and drinking, having his daily routine diet in order to post-evacuate the barium, and also preventing barium impaction, and ensuring that the patient, whether having the blurring vision or not after the Buscopan, and remaining the patient in the hospital in order until the barium will be, the blurring vision will be resolved. After that, it's single contrast. Each segment in that the imaging of single contrast barium enema, each segment should be seen at least two in the two films, and it's done by combination of fluoroscopy and with an X-ray fluoroscopy. Basic principle is you should have a distended colon, and also no overlapping of the loops, and a homogeneous barium suspension should be seen throughout the colon. Adverse reaction, usually it's very rare. We have constipation, we have barium perforations, we have tachyarrhythmias, and also we have transient bacteremia, we have the venous intravasitations also. The antibiotic prophylaxis, it's rarely used, but it's used for those patients having whether having any history of infective endocarditis, or having any hypertensive cardiomyopathy, those with vulvar diseases, or those patients whether having valve replacement. The patterns of enema will have barium enema. We have surface pattern, we have fold pattern, protruding breast, and contour abnormalities. Usually, the normal colon should have a smooth featherless pattern, surface pattern. The abnormalities in the surface pattern, reticularity, granularity, we have the cobblestonic, nodularity. In this image, we have the image, I don't know.
Yeah, what do you see?
Yeah, it's a double contrast barium enema.
Single.
Guys.
هذا single. Maybe هنا شوية أكوية. Okay.
Double contrast barium enema as a net-like.
You can see all of this.
As a net-like.
This is villus adenoma of the rectosigmoid. Adenoma is a polyp. It's a big one. Okay, here.
Here also.
Possibly here another one. Okay.
Yeah. And in the granularity, usually it's the early signs of the ulcerative colitis. You see a dot-like surface pattern, mucosal surface pattern. In cobblestoning, it's deep fissuring, and also the edema of the colon. It's double contrast barium enema, as I see, as it's mentioned in Crohn's disease. Fold patterns in this patient, there is a folding plating in an whether you have the exophytic masses in endometriosis or in any intraperitoneal lesion that lead to a mucosal pattern should be that folding on each other like plating.
Getting close to each other. شلون الأكورديون.
Same better.
Okay, it's getting close to each other in an endometriotic lesion here, and it's causing fibrosis. Okay.
And coil spring sign, it's like coils. When you use barium enema, double contrast, the coils that are intercepting the colon, the barium will be merged, trapped in the between the loops, and the outer loop will be
between the interseptum and intersepient.
Yeah.
Okay. There are two loops going into each other. So the barium is between them, trapped. Will give us this appearance.
Yes, this is interception.
Yep. This is going into this.
This could be due to inflammations
Mm-hmm.
that leads to these sinus folds that will be parallel to the long axis of the colon.
Mm-hmm.
Oh,
Good. So they represent inflammatory change.
Yeah. Protruding lesions, those lesions that are entering into the bowel, into the colon lumen, and leading to whether filling defects or leading to edged white appearance. If it's found in the dependent parts, it will lead to the filling defects, and in the other parts it will lead to the edged white appearances. As in this, it's like a filling defect.
Lead to what?
Edged white appearance. Edged white appearance, as in this case, the polyp. You see that the outer line of the polyp is covered with barium in a dependent area of double contrast barium enema. And we have Bowler hat sign. You should differentiate between polyp and diverticula. In the polyp ones, the direction of the Bowler, the hat sign, the hat one, they should be directed toward the long axis of the colon. However, in the diverticula, it will be away from the long axis of the colon.
The white part, هو الهات.
Yes.
So if the white part is to the lumen of the colon, this is a what? Polyp. If the white hat away from the colon, outside the colon, it's a diverticle. Okay?
And then we have the diverticuli one, and we have the polyp ones.
Like here,
Yeah.
the white is toward the colon. While here,
I think it's
this is what the collection, the white, it's away from the colon.
And we have Mexican hat sign. Two concentric rings. The outer one will be the pedunculated polyp, and the inner one the stalk.
Yeah, this is the polyp, and this is the stalk of it, like a little mushroom when you're looking. The stalk is the small one, and the hat is the big one.
We have familial adenomatous polyposis. Here, double contrast barium enema, you see the innumerable adenomas. And in these cases, you should do an elective colectomy in order to cause a risk of having colorectal cancer in the later stage. And the carpet lesions, those lesions in the lateral part of the cecum looks like carpeting or net-like projections, elevations of the mucosal edema, mucosal pattern. And the saddle lesions, those lesions where a lesion is making pressure on one side of the colon, looking like a saddle, and as in cases of inflammatory, I think also. So that's it. In annular, it's an like a leprechaun lesion. In cases of which the mass it making pressure on all around the colon, and making a shouldering and also narrowing of the lumen of the colon. And in cases of CA colon, and also it could be done could be seen in case of inflammation, ischemia in diverticulitis also. The press lesions in this double contrast barium enema, you see inner barium and also the outer halo sign. In case of Crohn's disease, it's an initial sign of the Crohn's disease. It's an image of aphthoid ulcer. It could be also seen in TB and in the amoebic diseases. And linear ulcer, looks like rose thorn. Yeah.
Rose thorn.
Yeah.
It's here.
It's a sign of the
Again,
Crohn's
ulcer
disease.
connecting body.
Yeah. And also we have the color button ulcer sign in ulcerative colitis. You see it's a broad base and also narrow neck lesion. That's it. Here there are extrinsic lesions in the outside of the colon that leads to pressure on the colon, as in cases of malignant melanoma, in cases of metastasis, lymphomas, gastrointestinal stromal tumors. And we have tapering. Tapering, it's a shallow, smooth narrowing of the colon, as in the sigmoid region. You see it looks like a bird beak sign. And it's the abdominal X-ray of that
sigmoid, which is due to sigmoid volvulus.
And we have circulations in ischemic colitis. It's a smooth out pouchings of the mucosa, as it's seen in the ischemic colitis in Crohn's disease also. We have spiculations. When you have an exophthalmic mass, whether neoplastic or dysplastic, that leading to pulling the mucosal, the luminal contour, leading to looks like a spikes in case of CA. Whether in inflammations also, sometimes you can see it. We have thumbprinting sign in it's mostly seen in ischemic colitis, but we can see it in Crohn's disease also. As a
thumbprint. You can see a thumb here and a thumb here and a thumb here.
And mostly in the splenic flexure cause of anastomosis of two circulations. And this one, it's a string sign, double contrast barium enema also. It's a severe narrowing of the luminal, the colon, the lumen of the colon, cause of the edema, fibrosis, and also the inflammation. And thank you.